I'd like to welcome you to our session on ethics and malpractice issues involving podiatric medicine and surgery. I'm Dr. Alan Jacobs, and with me is Dr. Jeffrey Shook. This discussion is being brought to you through the efforts of Kent State University College of Podiatric Medicine and Surgery and the Podiatry Insurance Company of America. Our discussion for today is that of documentation considerations in podiatry. And of course, when we speak about documentation, we're talking about medical issues and at times medico-legal issues, because documents are now used for multiple purposes. Medical records, of course, are primarily utilized to historically record medical care delivery. It's also used for malpractice protection, since we have a record of the care rendered, the indications for that care, compliance, and so forth. And also regulatory compliance. Third-party carriers will review these records to see if we are being compliant with their recommendations for evaluation and treatment. Governmental agencies such as Medicare may review these charts for regulatory compliance. So our medical records today serve multiple purposes. And if you don't think there is important concern regarding medical records, keep in mind that there's a plethora of textbooks, these are just a few, that are directed at regulatory agencies, attorneys, for techniques in reviewing medical records. This has become a very important issue. Now, if you're an old guy like me, you started with medical records looking as they do on the left. We had paper charts, we had nice file rooms like this, and those were the extent of medical records. And of course, we've transitioned to what we have on the right, which is the electronic health records system. If this doesn't look familiar to you with EHR, perhaps this is more representative of how you feel during the day dealing with EHR, which is of course understandable. A lot of the problem with medical records depend on how you were trained to do your H&P, whether or not you use the SOAP note formulation. One thing we know for sure is that doing detailed documentation takes a long time, thinking about everything that needs to be there for the patient's good, for malpractice protection, for third-party evaluation. Conversely, electronic medical records, by exploding documents and using pre-populated notes and using macros and micros, has made people lazy. And at times we are turning out notes that have little, if any, relevance to the actual facts in treating a patient, and these things can come back to haunt you. As you get older, you tend to want to write shorter notes. On the other hand, regulatory bodies such as Medicare want more and more detail. So the days are gone where one could write, for example, debridement of ulceration, no infection found. So today your justification for the ulceration, debridement, the size before and after, debridement, the appearance of the ulcer, the periulcerative tissues, the instrumentation used, instructions given to the patient, and so forth, are all now required, so that the issues involving documentation have become rather complex in the world that you are going into. You have various options. You can certainly be sitting there typing notes. That's inexpensive, but it's hard to focus on the patient while you're sitting there typing in a note. Voice recognition systems are relatively inexpensive, although there is a cost for software, but accuracy is a problem. There is a period of learning that's required with voice recognition systems, but it does free up your attention, and you have instant review of the note as it's being produced, which is nice. Scribes are certainly helpful. If you hire a scribe, you can focus directly on the patient. The downside is now you're responsible for salaries and benefits and everything that goes with yet another employee, including greater cost of practice. Or you could keep paper. And we still see people handwriting notes on paper. It's not as rare as you would think. But paper notes are hard to share. it does appear antiquated when it's reviewed by others, and it can result in delays in you getting reimbursed for your services with just handling paper claims. We live in a world of electronic health records now, there's no question about it, and one of the most important things that has arisen is that of HIPAA and data privacy, and this has become a critical issue, maintaining privacy and compliance with third-party requests. Why do we keep medical records? And this question comes up frequently in court. Well, medical records are there primarily to serve the patient. That is absolutely the #1 reason for medical records. Ultimately, medical records also are there to serve the doctor. And what's involved, the complexity of the medical record, really is dependent on what that particular doctor requires that serves them appropriately. Records are also there to serve future health care providers. A patient may transfer their care to another doctor, they may move, their insurance may change, and they're into a new healthcare system for whatever reason, and that future treater needs to see what has been diagnosed before, what's been done before, what was the thinking before. Unfortunately, many times, medical records are also utilized for medical legal considerations, and you always have to think about that possibility when documenting. And that is the medical legal implications of what's going into that record. More and more, your medical records are being utilized by third-party reviewers, whether it's a insurance payer or a government agency, but they're looking to see whether your records justify your billing, do they justify the treatment that was performed, and then records are sometimes utilized to see whether or not you followed the mystical standard of care. So as a student, as a resident, as a fellow, what are you told? Well, typical advice is document, document, document. But there's more to document than pushing a button and spitting out a preset note that talks for 5 minutes about tympanic membranes and thyroids being in midline and cranial nerves being intact, and having just one sentence on the patient has a bunion and it hurts, so I'm going to do surgery. So there's documentation, and then there's useful and important and relevant documentation. And then we always hear the phrase, if it's not documented, it's not done. And while we know that's not true, what is true is that good documentation is certainly supportive of what it is you saw and what it is you did. Now, not to beat this to death, because this is part of basic schooling, but just to recall, your documentation should include significant illnesses and conditions, medications that the patient is taking, because this is obviously going to influence some decisions you may make with relevance to procedures surgically, therapies you may prescribe, medications you may prescribe, allergies and adverse drug reactions. Smoking status is very important, and in some areas of medicine actually required. Alcohol or substance abuse history is important. Surgical history. Is there any history of wound healing or bleeding or anesthesia-related problems? Any history of DVT or coagulation disorders? Is there a history of protein C or protein S or factor V Leiden mutation or some thrombophilia? Does the patient has a history of DVT or pulmonary embolism? These are all critical issues. Then there has to be pertinent history, and all too frequently we find this lacking with electronic health records. And we have everything in the world in that record other than a detailed description of why the patient came to see you as the podiatric physician. Of course, your record's going to include an exam and clinical findings. One of the things that is important is, and not an uncommon source of litigation, by the way, is a failure to review laboratory data, radiographs, and vascular studies. If you order laboratory studies, if you order x-rays, if you order vascular studies, at some point your record should indicate that you reviewed that information and you document that you reviewed the information in any manner in which this is influencing your care. Obviously, if you reviewed vascular studies or determined that labs were indicated, there was a reason for that. Something motivated you to say, I need this information. And then the question becomes, was the information obtained? Did the patient comply with that request? And did you, in fact, review that information? It's a difficult situation when you order a test, it's not reviewed, the patient undergoes some therapy and was injured by that therapy, and in fact, it turns out that the results of that laboratory test or vascular study would have changed the therapy you would have rendered. Similarly with x-rays, all too frequently in reviewing charts, the only way we know x-rays were taken is we see the word X-ray, and we see a billing record for x-rays, and we see no comment on the x-rays. If you take x-rays in evaluating fracture healing, osteotomy healing, for whatever reason, then you should have some commentary in the chart that you reviewed the radiographs and these were your findings. Similarly with consultation notes. If you refer the patient somewhere for a consultation, there should be a note in the chart indicating that you reviewed that consultation note and followed up on those referrals. Lastly, make sure that you have a treatment plan that's consistent with that diagnosis, as well as a follow-up plan. Don't have a bunch of things listed and then no comment as to what it is you're going to do about those problems. Another common problem with documentation, in my opinion, is when dealing with medications. If you prescribe a topical, if you prescribe an oral medication, whatever you prescribe, your note should indicate why you selected the medication that you selected. What justified the use of the medication, and why did you select the medication that you selected? For example, you might elect to use oral steroids rather than anti-inflammatories, perhaps because of the patient's renal status, or a history of gastric ulceration, or some other reason, perhaps they're on an anticoagulant, and you feel safer using a steroid than an anti-inflammatory, although the anti-inflammatory typically might have been your first choice. Document that. Always document the dosage and that you discussed with the patient potential common side effects, and again, that you advise the patient to read carefully the printed material that will accompany their prescription or give them printed materials. And this includes topicals, the possibility, for example, of contact allergy, and who to call if they have a side effect, so that the patient was instructed to call Dr. Jacobs if any side effects, questions, or concerns arise. When you follow up with patients who are taking medications, make sure, number one, that you're updating your drug charts. Nothing looks worse than having a medical record repeatedly showing the same drug being taken for 3 years when in fact it was a 10-day course and you simply have not gone back into the record to take that off the active medication list. When you follow up with patients, your note should include the fact that you assess them for a response to treatment with that medication. Was it effective? The presence or absence of any side effects to show that you're monitoring that patient. If I use a tricyclic antidepressant, for example, for the treatment of symptomatic diabetic neuropathy, which I frequently do, I will document the absence of anticholinergic side effects, palpitations, tachycardia, weight gain, dry eye, dry mouth, things such as that, to show that I am indeed monitoring that patient for any adverse sequela. And do I need to modify the therapy, perhaps increase the dose, decrease the dose, change the medication? So turning out a 20-page note is no problem. If you clone, you simply push a button and the same stuff prints out. It's a repeat template over and over again. So exploding charts is common, very, very common. The problem is when you are reviewed, because it looks good on one chart, You look like a great doctor. You probably did an 8-hour examination. You've got everything in there from head to toe. But if you line up multiple charts from multiple patients, it looks terrible because you realize you're printing out the same note over and over and over again. And some regulatory agencies, such as Medicare, do not look kindly on this. They look at it as a form of fraud, arguing that perhaps this examination never really occurred. So, as a future practitioner, what are you to do? Well, I would say, number one, beware of electronic medical records. And think before you dictate. Don't just try to get that record done, but think about what's going on in the record, because that's a permanent historical preservation of that patient's record for that day. So think very much. What are some of the things that are lacking? And I'm going to use bunions as an example. It's not enough to just say the patient has a bunion, they want to have it fixed because it hurts, they tried wider shoes, and the x-rays show a big old bunion. You want to be able to justify why it is you're proceeding. All too often, we don't have, for example, disability. What is it the patient cannot do because of that bunion? What things can they not enjoy? How much pain are they having, and what type of pain is it? How would they rate that pain? What about patients that have nerve compression syndromes? Sometimes patients have a bunion, they pronate onto that bunion, and they may have paresthesia or dysesthesia of the medial proper branch of the medial plantar nerve as it crosses under that bunion. Or in the case of hallux limitus, sometimes patients have compression of the medial proper branch of the medial dorsal cutaneous nerve as it passes over the first metatarsal head, or passes, for example, over the cuneiform with a positive Tinelsen below. You want to document the need to do surgery to decompress that nerve, and the fact that the patient had pre-existing nerve injury. All too frequently, we don't see documentation for range of motion, quality of motion, and direction of motion. Now, this is important because the fact that a patient has crepitus or has limited motion or a non-reducible deformity may alter your surgical procedure. From a medico-legal standpoint, it's important because it shows that that limited motion following surgery was there prior to surgery and not the result of your surgery. And while you may have failed to improve that range of motion, you certainly did not cause that decreased range of motion or cause that arthritic joint. Similarly, the progressive nature of this deformity. Many people will tell you that their bunion is progressive, their hallux valgus is progressive, and you want to include that. When you determine the type of bunionectomy you're going to do, you do more than look at an x-ray. Given all the same x-ray angles, if you will, you're going to do something differently to a 18-year-old who's healthy versus a 76-year-old that has multiple comorbid conditions. The presence of growth plates, your own experience and ability, what the patient expects, the type of fixation you plan on using, metatarsal length, metatarsal width, the presence of metaductus, whether the patient's osteoporotic or not, whether they're able to rehab because of cardiovascular disease or pulmonary disease. All these things go into your decision as to what type of bunionectomy to perform. It's more than just looking at an x-ray. Those decision-making points should be in your record. They should be documented so that anyone questioning your judgment understands that your decision was made not just on an x-ray, but because of other general factors relating to the patient's overall foot structure, overall lower extremity function, and overall health. Because oftentimes that's exactly what we do. We may elect to do something like a Keller procedure or some variation of the Keller because the patient's old, and somewhat at a risk, and we want to do something that's simple and likely to be effective, and we concentrating on limited results rather than a perfect outcome. What about effects on adjacent structures? The patient that has a hallux valgus and maybe has not so much a painful bunion, but it's elevated their second toe, and now they have a painful lesion dorsal to the second toe or under the second metatarsal head. You may want to reduce the hallux valgus because of those effects. What about associated cutaneous lesions? How often do you see patients that have a bunion, that have a plantar medial first MPJ callus, or a plantar medial hallux interphalangeal joint callus, or a pre-existing submetatarsal 2 callus? All those things further justify surgical intervention and may affect your decision making. The rigidity of a deformity, the inability to reduce that deformity may make a difference. Now, of course, radiographic factors are important, but radiographic factors are just one piece of information that goes into the total decision on the bunion procedure you're going to perform. Expert witnesses who are critical of your procedures, should they fail to correct the deformity or should there be a recurrence, will invariably go to the x-ray and say, well, based on this PASA, this DASA, this sesamoid position, this IM angle, I most certainly would have done X, Y, or Z, and the failure of this procedure was predictable based upon these x-rays. Well, you're the one that examined the patient, you're the one that assessed the patient totally, and you've made that decision, as we've said, based on much more than an x-ray. And that's why that information needs to be in that record. And it's not going to be there if all you're doing is pushing a button and printing out a cloned, pre-populated note. In addition, what are the patient's desires? Some patients are willing to accept a limited result. They may say, I understand that a Lapidus procedure might be their preferred procedure, but I really don't want to go through that rehabilitation. I understand that if you do X, Y, or Z, I may be at some increased risk for reoccurrence, and I accept that. Make sure that your notes include a discussion of informed consent. Don't rely on just a printed piece of paper. Document that you have discussed with the patient the alternatives, the potential sequelae and risks, the possibility of failure, and that you have done that in a relaxed conversational means and that you personally discuss this with them. And this should include reasonable alternatives, and lastly, the objectives of the surgery. If I have an older diabetic patient who has an ulcerating second toe cord, my objective of that patient is not to get them a perfect toe, although ideally I would do that. The objective of that surgery is to lower that toe enough to remove that pressure to keep this from ulcerating. So I have a limited objective of that surgery. If I do a Keller-type procedure on an older person who has an ulcerating callus on a great toe or first MPJ, I have limited objectives for that surgery. And I want that understood by the patient, and I want that documented in the chart that this is the reason for which we are doing that surgery. Not to give them a perfect foot, because the conditions won't allow us to do that. And that should be documented. Again, do you need preoperative x-rays? Well, the issue is not getting preoperative x-rays. Obviously, they're important. Things like metatarsus adductus are going to influence our decision making. The degree of arthritis in the joint is going to make a difference in our decision. But our decision goes beyond just x-rays, in that in this particular study, for example, 21 surgeons were given preoperative weight-bearing and preoperative non-weight-bearing x-rays to see if, and make a decision as to what surgeries they would perform to correct a bunion. And it turned out there was no difference in decision-making whether the x-rays were weight-bearing or non-weight-bearing, which sounds like podiatry heresy, but actually represents a reality. So we make decisions based on more than just x-rays. Some people are able to get wonderful corrections doing Austins on the majority of their patients, and they do well with it. Some people get wonderful corrections doing Austin Aikens or proximal first met Aikens, and the x-rays in some of these patients might belie that determination. Make sure that what you're doing is consistent with why the patient presents, and remember that things have to correlate, meaning x-rays and your notes. And here's an example. A patient comes to see a doctor and her complaint was an ingrown toenail. The ingrown toenail was corrected, and the patient returns with a, quote, new complaint of a painful bunion. Now, there was no documentation actually that the patient had tried things like padding or anti-inflammatories, but here's the point. The note indicates that there's an increased intermetatarsal angle, increased hallux abductus angle, moderate hallux valgus, medial prominence to the first MPJ. Now, all of that sounds good as an indication for surgery. Here's the problem. Here's the x-ray. And unfortunately, this patient went on to develop some rather substantial complications from the surgery performed to correct this bunion. So there's no correlation whatsoever between this x-ray and the note suggesting that this patient had a high intermetatarsal angle, had a hallux abductus, and had a significant deformity. So make sure that things correlate before proceeding, because this is not going to support a note that indicates this. So give a little thought to your notes. Here's another example, one that's a particular bone of contention by me. Anytime we do surgery now, we have these checkoff sheets for patients' threat for DVT. And as you know, we have various scoring systems. So before you can take the patient back to the OR, you have to sign one of these sheets that has a score. And if you think about it, many of the patients undergoing foot surgery, because it's lower extremity, and there may be some degree of immobilization, and whatever, end up with scores that place them at increased risk for DVT. You have to account for this, because you now have signed a document placing this patient at, say, moderate risk for DVT, even though you don't believe that to be the case. But you throw in a tourniquet, you throw in their age, you throw in its lower extremity, you throw in there's some degree of immobilization, and God forbid that patient develops a DVT or pulmonary embolism, you can pull this sheet and say, well, doctor, you assess this patient, you sign this sheet, and it clearly indicates that by your own assessment, this patient was at risk for a blood clot, and you did nothing about it. So that you need to be very, very careful in your preoperative assessments of what you're signing. I want to speak for a minute about observations on intraoperative notes. All too frequently, we allow residents to dictate our operative notes, and I'm not sure that they always know what is important to put in a note. It's always intriguing to me that our medical colleagues will do a total hysterectomy for cancer, and the operative note is maybe 3/4 of a page. And a patient will have a bunionectomy and a couple toes done, and 6 pages later, you're sort of falling asleep because you're not sure if you inadvertently tripped onto a PhD thesis. And it's not the quantity of information, it's the quality of information that's there. Number one, intraoperative findings. When you determine to do a particular procedure, take the time to dictate that your observation in the operating room substantiated or verified or supported your decision to proceed with the anticipated procedure. Now, of course, that's not always going to be relevant, but let's say you decide to fuse a first MPJ, and You want to have a note that says something to the effect that the joint was grossly unstable or that there were arthritic changes present. You want to support what it is that you did. Obtain intraoperative radiographs. Now, this is not the, quote, standard of care. And I don't believe it's ever a malpractice not to obtain intraoperative x-rays, but I think it's stupid not to obtain intraoperative x-rays. Because if there's a problem with alignment, if there's a problem with fixation, the time to correct it is while the patient is in the operating room. Because sometimes post-operative x-rays show problems that have occurred, and then the question becomes, did you allow the patient to leave the operating room with this dislocated osteotomy, with this non-reduced fracture? And the eye in the sky don't lie. So obtain multiple view x-rays where they're going to be significant. If there's been an osteotomy with fixation, if there's been fracture reduction, if there's been an arthrodesis. And remember the basic rule. If all the x-rays show that the screw is where it should be, then it's where it should be. If all the x-rays show that the screw is not properly positioned, where the fixation is not properly positioned, it's not properly positioned. And if one of the x-rays show that the screw or fixation may not be properly positioned, it's probably not properly positioned. So you need to get multiple views and save them for the medical record to show that when that patient completed their treatment with you in that operating room, things were where they should be. And also dictate abnormal findings that are present. If someone's going to challenge a procedure, make sure that you dictate that the procedure accomplished its intended purpose. For example, you may have a large intermetatarsal angle, and after soft tissue release, that IM angle reduced enough to allow a distal metaphyseal osteotomy to then be effective. Document that. It may be that you were planning on doing a distal osteotomy, but the width of the bone was too narrow to allow adequate transposition, so that the soft tissue release and the width of the bone conspired not to allow adequate reduction, and so you determined to modify the procedure because of that. Well, you document that decision. It may be that you altered your fixation choice because or osteotomy configuration because the bone was of poor quality. Document that. It may be that you encountered a higher proximal articular set angle or more degenerative changes than you thought or had anticipated. Document that. So here's a patient who had an Austin done, and inadvertently the second metatarsal was osteotomized at the same time. The doctor who did this was unaware that the second metatarsal had been osteotomized and no intraoperative x-rays were taken. Instead, this x-ray was taken on the first postoperative visit of the patient to the doctor. The doctor saw the x-ray and immediately told the patient, you've developed a stress fracture of the second metatarsal, now we need to go back and fix it. And I think the doctor would have been okay, I suspect, had they not deceived the patient. But no one's going to look at the alignment of those two cuts, which are absolutely parallel, and say that was a stress fracture that occurred 3 days following an osteotomy. And I feel the same way, and again, it's not standard of care, and I don't want anyone listening to this tape to suggest I'm saying that. But again, I question doing x-rays in the post-anesthesia unit. You're probably dressed and on your way to the office or wherever. Now you've taken x-rays in post-anesthesia, which I suppose is better than no x-rays, but what are you going to do about poor alignment or poor fixation in the post-anesthesia unit? Why not have obtained those x-rays in the operating room at the time you did the procedure so that you could make the appropriate correction or adjustment at that time? So did this patient require reduction in fixation? Of course they did. Would it have been better if it did not require a second trip back to the operating room? Of course. because as my old professor, Dr. James Ganley, used to say, no one likes going back to the operating room a second time. So this would have better been fixed during the time of the first surgery, and the patient told at that time, we inadvertently cut the second metatarsal, I fixed it while you were in there, I don't anticipate there's any problem, rather than saying you had a stress fracture. The patient goes and sees an alternative doctor who says, well, I don't think this was a stress fracture. I think you were given perhaps incomplete information. And again, I mentioned earlier, and this is a common problem with charts, and that is we take x-rays and don't comment on them. And this was a study that indicated just that. It was a look at 274 scarf bunionectomies. Only 86 of the patients actually had postoperative x-rays. 14% of the patients had no x-rays. And not infrequently, there was no comment in the chart regarding the x-rays. If you take an x-ray after surgery, there's a reason you're taking that x-ray. So make a comment regarding your evaluation and treatment. Here, for example, is a patient that had bilateral long arm Austins. And I don't think most of us would think this is a particularly good looking osteotomy on either foot. And yet, there was absolutely no comment by the surgeon as to the problematic healing that was ongoing. And it makes you look inattentive, if nothing else. So make sure that, there's appropriate commentary. I'd like to say a few words about discharge instructions. These are critical. And don't just sign off on discharge instructions because you're in a hurry and you assume what's there is adequate for you. Make sure these are individualized because sometimes discharge instructions have recommendations and directions to the patient that are not consistent with what you want to do. In fact, they may be contrary to what you wish to do. So if a patient requires the use of a medication, if they require non-weight bearing, if they require ice application, whatever your recommendations are, make sure they are on that sheet. Otherwise, if a patient suffers harm, they will say they were not instructed to do the things that you will maintain they were instructed to do. They will pull this sheet out and say, doctor, can you show us where this patient was given instructions to do these things that you maintain they were told to do. So don't take these home discharge sheets lightly. Make sure that they have the information there that is consistent with what you believe to be the best postoperative care for that patient. Ultimately, we see these patients back in our offices and make sure that the notes indicate that you have a true assessment of that patient. Ask them about fever and systemic signs of illness or the absence of that, no chest pain or orthopnea or dyspnea or cough or rash, that they're doing well. Check them for DVT. Do a Homan, do a Pratt, ask them about pain in the leg or thigh, and document that you have evaluated them for any signs or symptoms of deep vein thrombophlebitis. If you've done an osteotomy or fusion, assess it for stability. Because remember, x-rays trail actual bone healing. And sometimes you'll be making decisions to allow a patient to walk, weight bear, prior to the time that the x-ray shows solid consolidation. So healing is determined by clinical examination, not by x-ray. So document that the osteotomy or arthrodesis was stable to manipulation, that the deformity was reduced, that the hardware was in proper positioning, it was not palpable, and of course document their neurovascular status and any instructions given to the patient. You also want to always document any pain or discomfort and whether or not the analgesics given are adequately caring for this patient's needs and hopefully that they're showing declining need for analgesics and not increasing needs. One of the things I cannot emphasize enough to students, residents, and fellows is that other eyes are watching that foot. So make certain that your notes are honest, accurate, and representative of what's going on. For example, your patient may be going to physical therapy, and you're documenting that they have a very good range of motion of their first MPJ, and the therapy notes all show severely limited motion and pain. It may be that the patient is receiving wound care, and you're documenting how their wounds are progressing, and there's not a lot of necrotic tissue, and they don't appear to be infected. And meanwhile, the home nursing care notes have different measurements and a different description of that wound that conflicts with your description. Or they may be seeing other healthcare providers. They may be seeing a primary who's panicked over the appearance of a wound and stating this is infected and they need antibiotics, and your notes are saying, no, they're just fine. So you have to assume at times that others are looking at that wound, looking at that incision, looking at that fracture, looking at that patient, and make sure that your notes are consistent with what's going on. For example, here's a note that indicates the patient has a superficial ulceration of the proximal 1/3 of the incision. The patient is home taking pictures of their foot, and here you can see the superficial wound. If you look carefully, you can see the superficial extensor hallucis longus tendon, and if you look carefully, you can see the superficial screw, and you can see the superficial bone graft interposed in this joint, which was a Lapidus procedure with an interpositional graft. I think you need to assume at this point in time that everyone is taking pictures of their foot. They're using their cell phones. Everyone's taking pictures. They'll do it right in front of you in the office, and you'll ask, well, why are you taking pictures? And the answer is, oh, my daughter in California was just curious to see what my foot looks like. And so you have to have notes that are honest and accurate, because if the notes conflict with reality of the photographs, it can be difficult to maintain the honesty and accuracy of your notes. And this was a perfect example. And patients are always taking pictures of their feet. They're taking their dressings off. Here's another example. Here's a post-Austin post-op visit. And I don't think anybody looking at this x-ray would be particularly happy seeing this. And yet look at the note. Slight varus toe. Well, I mean, I think we can agree this is hardly a slight varus toe. So here again, there's an inconsistency between reality and the note. And just because you say in a note it's so, doesn't make it so. So your notes have to be accurate and effective. And you'll notice there was no reduction of this. It says condition is progressing as expected post-operatively. I would hope this doctor this is not his typical post-op Austin bunionectomy. It's frightening to think that could be. And instead, we're talking about orthotics and coming back in 3 weeks. And you can understand how poor documentation like this makes it very difficult to justify the doctor's approach and defend the doctor for problems. You know, things like this. Here's a photo of my left foot, shows first and second toes are still crooked after first surgery on 6/6/12. Patients are doing this all the time, and you've got to assume they're doing so. This is a public record, so don't worry about the face being shown. It was from a lawsuit, but this is a fellow who had an osteomyelitis of his baby toe and goes and sees a podiatrist, and the podiatrist recommends hospitalization because he feels the guy is septic. He does not call the family, does not call anyone else in, but sends the fellow home, and he's a bit senile. So he goes back and he sees the family, and they say, well, what did the podiatrist say? And he said I had a corn and he trimmed my corn. Well, the guy ends up in the hospital, septic, and died 48 hours later. Now, here's his toe, and here's the poor fellow dying, and the family is taking pictures of the foot. Now, other than the purposes of a lawsuit, I would question, why are you taking pictures of your father's foot on his deathbed? And of course, an inquiry comes from a plaintiff's attorney suggesting that this was the podiatrist's fault, which of course it was not, and everything was straightened out. But the point is the documentation on this visit was horrible, and it made it difficult at first to defend it. This was a patient who was an elderly diabetic who was prescribed an ice machine for post-op pain, and she fell asleep from the analgesics prescribed and developed a frostbite injury of her foot. And here again, the family is taking pictures of the frostbite injury before they ever went back to see the doctor who was treating this thing and turn it into a Kodak moment. So remember, other eyes are looking at these feet. Here's a fellow who, in between cigarettes, had a wound breakdown from a neuroma surgery on the bottom of his foot. And what's he doing? He's taking his dressings off at home, smoking, which was great for us because we were able to use that as part of our defense. But the point is, as serious as this wound was, he's just taking pictures of his foot. So assume that patients are doing this. Non-compliant behavior. Non-compliance is a common cause of treatment failures. Again, it is something that is very much unrecognized, and it is common. And it can be failure to stop smoking, failure to offload, failure to take medications, failure to do the things you've requested them to do following surgery. Here are some common examples. For example, as podiatrists, we very frequently treat chronic venous insufficiency, and we prescribe, for example, compression stockings. And many patients either never purchase the stockings, purchase them and don't use them, or never follow up with additional purchases. Looking at the Ponseti treatment of clubfoot deformity, we know that properly done, generally a 90% success rate is associated with standard Ponseti casting. And yet, if we look at recurrent clubfoot deformity, the most common cause of relapse is failure of the parents to utilize the post-casting bracing that is typically required in treating these patients. Patients who have Achilles tendinosis, for which we give instructions for home physical therapy with stretching. The majority of patients don't comply with our request for stretching. Looking at studies on compliance, most of which evolve around medication use rather than physical therapy, we see that even in controlled clinical studies, where patients are given free medical care and only required to take the medication that's part of the study, compliance rates can be as low as 43% and as a maximum 78%. We know that many hospital medication-related admissions are due to non-compliance, and we know that even patients who have serious diseases like diabetes, hypertension, or medications for dyslipidemia take their medications 80% of the time, less than 60%, and 80% is considered the standard for compliance. So was the patient compliant with your instructions? Well, again, it's important to chart in your medical records instructions to the patient. What are they to take? When are they to take it? What are they to do? How are they to do it? How often are they to do it? In an ideal world, you would also include written instructions together with charting notes indicating what they were instructed. Your operative note, your discharge summary, and your discharge instruction should include specifically what your recommendations are for post-operative care, and each of your follow-up notes in the office should include a discussion as to whether or not the patient was compliant, and if they weren't compliant, you should document the effects of that non-compliance and the fact that you've re-instructed the patient on what was required and re-instructed the patient as to the potential complications or sequela that could occur from their continued non-compliance. Now, when you document non-compliance or any relevant event, if it occurs in an institution You want to make sure you fill out an appropriate incident report. And you always want to include this in the patient's record. Make certain that your documentation sounds and is objective. Don't use the non-compliance as an excuse to try to explain away perhaps less than adequate reduction of an osteotomy or less than adequate fixation placement. But instead, be objective. Talk about what happened. Talk about how you perceive this has affected or is going to affect the outcome. But don't make it sound as though you're creating some type of exculpatory evidence to explain away every ill that's occurred in this patient's, because it doesn't look good, it doesn't sound good, and frankly, it's just not honest. And obtain second opinions when necessary. Smoking. Smoking is an issue because it's associated with an increased risk of complications with surgery and complications with healing, such as wound healing. We know that smokers and former smokers have increased risk for infection, delayed or non-union, pseudoarthrosis, vascular complications, and problematic soft tissue healing. And there's lots of studies that show that, for example, with ankle fusions, that the risk of non-union is increased 16 times in a smoker versus a non-smoker. Or subtalar joint arthrodesis, 20 times higher rate non-union in a smoker than a non-smoker. Or even things like the Austin bunionectomy, where we know that not only smoking, but secondhand smoking delays healing of these osteotomies, so that from ankle to Austin and everything in between, we have clear evidence that smoking is associated with poor outcomes. Now, interestingly enough, this was a survey of foot and ankle orthopedic surgeons. 99% stated they were aware that smoking was deleterious to healing. Only 84% documented that the patient smoked, but interestingly, only 1 in 10 warned patients of the effects of smoking in their consent form. However, about 1 in 4 doctors admitted that in a smoker, they altered their surgical approach to decrease the demand for healing because of smoking. So you want to document these things and advise discontinuation of smoking. Advise the patient of the risks. Generally, the recommendation is to document 2 weeks prior to surgery. If you're going to do surgery in a smoker, my recommendation is that you document a stronger indication for the need for surgery, perhaps recommend a referral for smoking cessation, and please get vascular evaluations on smokers. Now, smoking does not equal peripheral arterial disease, but we know that smoking is associated with increased risk of peripheral vascular disease. In my opinion, the worst case scenario is that there's a complication, and at some point, the attending doctor attributes that complication to smoking and blames the patient and says, this is your fault because you've been smoking and that's why we had this problem. But you got to understand the other side of this, which is a plaintiff's attorney is going to say, well, doctor, are you saying that smoking is bad for healing? And you're going to say yes. And in fact, doctor, you've documented that in your opinion, smoking is what caused my client to have this awful, terrible outcome. And you're going to say, absolutely. And then they're going to say, well, doctor, if you knew that, why didn't you advise my client to discontinue smoking? Because my client absolutely would have given up smoking if he had been told this terrible thing can happen. And there's nothing in the chart. So I think it's important to confront smokers and make them responsible for potential poor outcomes that are going to occur in association with smoking, and encourage them as best you can to discontinue smoking. And if, in your opinion, a surgical procedure is seriously likely to be compromised in a smoker, then consider not doing the procedure. Why do you have to document everything? Here's another study from the American Orthopedic Foot and Ankle Society. This was a study in which they wanted to see how much do patients recall you telling them prior to surgery. So they had a standard list of 11 complications that could occur after a bunion procedure. And they waited till the sutures were taken out, and then they went back and said to the patients, by the way, do you remember we gave you that list of things that could happen to you when you had a bunion done? And yeah, could you name them for me? And on average, patients have no recall of surgical risks discussed with them. On average, they can remember 1, and at most, they can remember 4. And that is another reason why documentation is so important, because patients are going to tell you they were never told any of these things. And smoking should be, again, reinforced in the op note that they were told to discontinue smoking and warned about this in their discharge summary and in their discharge instructions, that they are not to smoke. And this is all very, very helpful. When you see the patients back, you ask them in a non-threatening way, did you stop smoking? The chances are they're not going to do that, and you repeat to them their warning and what can happen, and document it on every visit. Lastly, I want to end with what I think is a perfect example of bad documentation and how documentation could get you in trouble and why you have to think. So this is a patient who's an older diabetic who's coming in to see a podiatrist to have toenails debrided. And because the patient is a Medicare patient, the doctor is constructing notes that satisfy Medicare requirements. So we see under objective, advanced skin changes in the form of lack of hair growth, dry, shiny, textureless skin. Skin color is cold, pale white pallor, and diminished pulses. And for years, the patient is getting the nails debrided, billed to Medicare with this same note. Here's another one, advanced skin changes, lack of hair growth, dry, shiny, textureless skin. Skin color is pale, white tone, red, blue, purple, mottled appearance, diminished pulses. My God, you know, it's no wonder Medicare will pay for this. We certainly don't want this patient cutting their own toenails. This is just terrible vascular disease. And here's another one, diminished pulses, bilateral, and diagnosis under assessment, onychomycosis and ASO, arteriosclerosis obliterans. Well, this is certainly meeting Medicare requirements. And here we go on and on and on. Dry, cool, hairless skin, and now the patient has onychomycosis, contracted joints, and arteriosclerosis obliterans. And what does the doctor then do? He decides to do hammer toes by doing everything you can to kill the toe. We use local anesthesia with epinephrine. We do extensor and flexor tenotomies. And of course, predictably, we end up with an amputation. Now, is this a great tragedy, losing a toe? Of course not. But look at these records and say to yourself, if you were a defense attorney and you've got 2 years of notes saying this patient's circulation is so horrible and so bad, we don't even want them cutting their toenails. We will do it and have the government pay for it, and you then go and do hammer toe surgery and do it with epinephrine and cut the top and bottom of the toe. How do you defend a case like this? And to me, this is a perfect example of how charting gets you in trouble. So, and of course, final diagnosis was gangrene. So, in summarizing this, your notes should always be objective, not critical or subjective. They should be clear, concise, and comprehensive. Make sure that they are accurate and reflective of your observations without unfounded conclusions, and make sure they are truthful and honest. Do not create notes that appear to be self-serving, especially if an incident or injury occurs. And I leave you with this quote, because if you mess with lawyers, you always want to remember what Don Corleone said: a lawyer with a briefcase can steal more than 100 men with guns. Thank you for your attention to this presentation, and thank you to the Podiatry Insurance Company of America and to Kent State University.